Hello, my name is Ruth for Olaya Rojas, and today I'm going to talk about preserved renal-allograft function and the PD-1 pathway inhibitor Nivolumab. First, we are going to start with definitions. PD-1, a protein found on T cells, a type of immune cells that helps the body keep immune response in check. When PD-1 binds to another protein called PD-L1, it helps prevent T cells from destroying other cells, such as cancer cells. Some anti-cancer drugs called immune checkpoint inhibitor are used to stop PD-1 from working. When this protein is excluded, the brakes of the immune system are released and the ability of T cells to kill cancer cells increase. Nivolumab. It's a drug that binds to the PD-1 protein to help immune cells kill more cancer cells and is used to treat many different types of cancer. It is usually given intravenously over 70 minutes every 2 weeks. The amount of nivolumab you will receive depends on many factors, including your general health and other health problems, as well as the type of cancer or of illness that suffers. Renal-Allograft. It's a surgical intervention that is performed when you are in advanced stage of kidney disease, stage 4 and 5. This means that the kidney stops filtering the blood, allowing harmful levels of fluid and harmful weights to build up in the body.
As a scientist, I specialize in cancer immunotherapy. My work, and that of my colleagues, is to figure out ways to stimulate the immune system to kill cancer. To understand this concept, let's talk a little more about our immune system and how it works. Taking a look inside our body, all of us are born with an immune system that acts like the security checkpoint at the airport. Our immune system is like a high-tech full-body scanner system that protects us from things that are harmful. In the immune system, T cells have receptors that scan cells to distinguish between normal cells and abnormal cells, like virus-infected cells. Once detected, abnormal cells are attacked and removed by T cells. T cells also identify these cells for future recognition. The same T cells also play an important role in protecting us from cancer. Cancer cells are normal cells that have mutated. The more mutations cancer cells have, the more easily they are detected. Until recently, we didn't understand why T cells were detecting these cancer cells but not destroying them. But on a closer look, we've made some revealing discoveries. We've learned that one of the ways that cancer cells get past the security system is with the help of a molecule called PD-L1 that is found on the surface of cancer cells. PD-L1 is almost like a disguise that allows cancer cells to remain undetected. PD-L1 basically hacks the T cell scanning system by jamming the signal to parts of the T cell system called PD-1 and B7-1. Think of PD-1 as a sensor that's part of the T cell scanning system, and B7-1 is like an alarm that issues an alert when something is wrong. When PD-L1 hacks the system, it prevents it from doing what it's supposed to do. In other words, it may prevent T cells from destroying cancer cells. Scientists have been working on fixing this problem and have designed molecules to target the PD-L1 PD-1 pathway. You can think of cancer immunotherapy as kind of like a software update for your immune system. Early studies suggest that by targeting the PD-L1 PD-1 pathway, T cells may be able to detect and destroy cancer cells. Let me show you in more detail. T cells have receptors that allow them to recognize cancer. Cancer cells can prevent elimination by turning on PD-L1. PD-L1 deactivates T cells by binding to PD-1 and B7-1. Blocking PD-L1 from binding to PD-1 and B7-1 could prevent PD-L1 from communicating with them. When this happens, T cells may finally be able to respond and kill cancer cells. Clinical trials are currently underway to understand the effects of trying to block the PD-L1 PD-1 pathway in the body. We are committed to studying cancer immunotherapy so that we can continue to find new ways to harness the immune system to fight multiple types of cancer. Genentech, a member of the Roche Group.
Applications in medicine. Um, Inhibition of immune checkpoints with the use of antibodies targeting programmed cell death PD-1 or monoclonal antibodies against cytotoxic T lymphocyte associated antigen 4 CTLA4 has been used clinically in patients with various types of cancer. In the limited number of report cases in which these antibodies have been used in patients who have undergone kidney transplantation, these agents have been associated with cells mediated and antibody mediated rejection.
Welcome back. In this video we'll be talking about transplant rejection. We have three main types of rejection: the hyperacute, the acute, and the chronic. The hyperacute rejection, which is also called the white graft rejection, is caused by type 2 hypersensitivity, and it occurs in minutes. So the surgeon can see the organ failing before he finishes the surgery, and it appears white, and that's why it's called the white graft rejection. The cause is pre-sensitization of the host to the donor, which means the host already has immunity against the donor cells. Under the microscope, we're going to see ischemia and neutrophils causing necrosis. We will also see thrombosis. Acute rejection, which is the most common, is caused by type 4 hypersensitivity and usually takes months to occur. In this type, the host will slowly develop antibodies against the donor. Under the microscope, we're going to see T-cell mediated endotheliitis. It's usually asymptomatic, and we diagnose it before the patient have any symptoms, because in the period following the surgery, the patient will be under close follow-up and close observation, and we can diagnose any changes before the patient have any symptoms. It's also very common in heart transplants. In chronic rejection, we have both type 2 and type 4 hypersensitivity, and it takes years to develop. In this type, the host will develop antibodies after exposure to the donor. Damage is mediated mainly by cytokines. In renal system, we see mesangial hyperplasia. In liver transplants, we see vanishing of bile ducts. In heart transplants, we see atherosclerosis of the coronary arteries. And finally, in pulmonary transplants, we see bronchular thickening. And here's a small quiz for you. So where do we see cyanotic organ rejection? And in chronic type, do we see T cells or B cells infiltration? And here are the answers. Alright guys, that's everything I've got. Hopefully I made this easier for you. Thanks a ton for watching, and I'll see you guys later.
Pros and cons. Pros, we have that kidney transplantation it's a therapy of choice from most cause and end-stage chronic kidney failure because it improves quality of life and survival against dialysis. The introduction of powerful new immunosuppressants has allowed an excellent graft survival rate in the first year, but there is controversy in a longer term. Nivolumab can be used in people who advanced kidney cancer begins to grow again after target therapy drug treatments and has been shown to help people live longer. Cons. Associated disease that could reduce graft survival, example severe heart disorders and cancer, which can be detected with routine tests. Uh, Despite the use of immunosuppressants approximately 20% of kidney transplant recipients have one or more rejection episodes during the first year after transplantation. Chronic graft nephropathy refers that graft failure or failure 3 months after transplantation. Most cases are attributed to cause such as calcineurin inhibitor toxicity, eh, diabetic hypertension, nephropathy type 1, polyomavirus infection. Compared to general population, kidney transplant recipients are around 10 or 15 times more likely to develop cancer, likely due to decreased modulate immune system response to cancer as well as against infections. Issue apply in Ecuador. In Ecuador, it is estimated that more than 800 people are on the waiting list for organ transplants. For this reason, the uh, aim of this study is to describe the epidemiological profile of patients on the waiting list and donor for a kidney transplant. Currently, there are five accredited centers of kidney transplantation in adults and one for pediatric kidney transplantation in Ecuador. Conclusion: immunotherapy can lead to acute allograft rejection in solid organ recipients. The treating nephrologist and oncologists should be aware of this complication, and patients with cancer should know about their therapeutic options in order to make the best treatment decision in line with their lifestyles and goals of care. In some cases, the benefit of tumor regression may outweigh the unavoidable complication of allograft loss, especially in the setting of advanced metastatic tumor. Thank you.